Good morning. Welcome to the first in our series this week of the CMREN hosted educational series, Substance Use Disorder in the Subpopulations. As we get started this morning, just a few housekeeping things. As you can see on the slide, you can claim CME CE credit by going through these steps. I will put the link in the chat box for you to go to med.cmich.edu/CMECERT so that you can claim credit and then to enter in to get credit for your certificate for today's CME options. Today we will host a speaker, and after the speaker, we will answer Q&A. So during the event, if you would just write your questions into the Q&A link at the bottom of your screen, we will read through those and answer as many of those questions as we can during the time allotted. So thank you so much for attending today. And at this time, I would like to welcome our speaker today. Today, joining us is Dr. Chad Brummett. Dr. Brummett is a Senior Associate Chair for Research in the Burt N. Ledoux Professor of Anesthesiology in the Division of Pain Medicine at the University of Michigan Medical School. Dr. Brummett joins us today also as one of the leads for Michigan Opioid Open, and an opioid-funded project that he is working on as well. So Dr. Brummett, we welcome you today. Thank you.
Great. Well, thank you very much for having me, and it's a pleasure to be here today. Can you see my screen okay? Can I just get a thumbs up?
Thank you.
Okay, wonderful. Okay, great. So as Gail noted, I'm Chad Brummett. I'm an anesthesiologist, the pain physician at the University of Michigan, and I'm going to talk today about acute care prescribing. So thinking about surgery, dentistry, and emergency medicine, and its role in the opioid epidemic. And I think many have heard opioid-related lectures, but I hope today will make you think maybe a little differently about things that haven't really received as much press. So I have a number of funding sources from the NIH, the Common Fund, as well as Michigan Department of Health and Human Services, SAMHSA, the CDC, and really the state's been instrumental in driving a lot of this work and helping us fund a lot of this work, as well as some institutional funding from the Precision Health Initiative and the Department of Anesthesiology. I have an unrelated patent, and I have a couple of companies with whom I consult, but I won't talk about any of their products, and I do a little bit of expert testimony, and again, won't talk about anything related to that today. So, as I said, I think everybody talks about and thinks about the opioid epidemic. Pre-COVID, it was everywhere. I think now as COVID is waning, we hope, this last surge has certainly been a bummer, but as this last surge of COVID is waning, I think people are starting to talk about opioids again. And it strikes me that, years ago, when I would give this lecture, I would say 78 Americans die every day from opioid-related overdose. And that seemed like a staggering number. And then it went into the 90s and then a low 100s, and now has kind of over the last few years hung around 130. In fact, we actually celebrated the year that it went from 134 deaths per day to 130. And we saw the last administration talk about us really turning the tide on opioid overdoses, but it's a really staggering number to still lose 130 Americans every day. And unfortunately, and now we've seen this, there are data coming out that amid COVID and in this last year, for probably some obvious reasons, including social isolation, anxiety, loss of work, all of these things have probably driven our overdoses up yet again while we wait on the data. And the numbers matter. The numbers matter a lot. And generally, I tend to tell a story, but I guess the way I would structure this is just to say 130 can sound like a lot, or it can sound like a lot of other people. But as I've traveled around the country, and really even outside the country, I've heard lots of stories. And those stories are really deeply personal. And when you're one of those 130 deaths, when it's your family member, your child, your mom or dad, these things matter in a way that a number can't ever show. And I think that we have a lot of stigma when it comes to opioids. But what I would say is that this happens across all demographics, all family types and really matters to everyone. And here in Michigan, we have seen a lot of overdose. And I was just with the DEA last weekend doing a take back drive and heard that we are seeing a major surge in heroin, cocaine, and methamphetamines throughout our state. Well, 130 deaths per day, but where are we with prescribing? And these are the data for prescribing. We know that year over year since about 2011, which was the peak of opioid prescribing, during that peak, hydrocodone was the number one prescription. That's the product that's the generic for Vicodin or Norco. That was the number one prescription in America, not number one opioid, but number one prescription in America. And during that time, around 2010, 2011, we were 5% of the world's population, yet we consumed 80% of the world's opioids. And I am board certified in pain medicine. I take care of patients with pain. I do use opioids in some of those patients, and I believe that opioids have a role for acute pain. However, I can say with the greatest certainty that vast consumption of opioids that we have shown in our country has not made people healthier or better. We have not led to better pain care through this vast use of opioids, this disproportionate use. But year over year, we've had decline since 2011. And so you would think that would be good, but people love to point this out to me. They love to push in this most recent, these data showing that year over year, despite this decrease in prescribing, we're seeing an increase in opioid-related deaths. And I already hinted at this. We're seeing a lot of fentanyl and a lot of heroin and a lot of polypharmacy, cocaine, methamphetamines, alcohol. Alcohol has been up a lot during COVID. And so this is really what's driving the prescribing. So people will come at me via Twitter or other mechanisms and say, this is proof that you can decrease prescribing and it won't decrease overdose. And I would agree that decreasing prescribing alone won't change overdoses. But I think anybody who says that really fails to see the full picture, which is that in the early to mid 90s, with the release of oxycodone and OxyContin from Purdue Pharma, and there's tons of lay press out there. In fact, there was a really good NPR last week, I think it was on Fresh Air, about the Sacklers and a new book that just came out. I highly recommend listening to it. But we saw this increase in marketing and prescribing of oxycodone, and with that, a delayed but associated increase in mortality that continues today. And while this spike that we've seen since probably 2015 is largely related to heroin and fentanyl, still about a third of our opioid-related overdoses are from pills. And the vast majority of people who start using heroin begin with a pill. In other words, not starting it just with heroin. And I think that is an important narrative. And we maybe are seeing some changes. We continue to see declines in prescribing, but we'll see what happens. My guess is that our net overdoses for this next year will be higher. Now, our group came together in late 2015, 2016, and said that this, and this will be most of the work that I described today is over the last few years, is that the whole country, the U.S. Government, the FDA, the CDC, the NIH, everybody was focused on all of the downstream effects of the opioid epidemic, what to do with the person already using opioids, how to better manage opioid use disorder, how to get naloxone in the community. Really important topics, all certainly merit more funding. But at that time, nobody was really talking about this. If I came to one of your hospitals currently today, if I came in and I said, who is using an opioid before surgery? We know that probably 80% are not using opioids before surgery. It's actually about 20% of people use opioids in some fashion before surgery, whether it be intermittently or chronically every day. People are using opioids, but that meant that the majority of the people for whom we were caring were not using opioids. And we were only focusing on that 20%. And as compared to going to like a primary care physician's office where I could sit in the waiting room and really struggle to know who's going to get an opioid, understanding who's going to get an opioid for surgery or dentistry is actually very simple. If you give me 2 weeks worth of data from your hospital from the weeks before, I can tell you which patient's going to get an opioid and how much they're going to get. Because the only two factors that really matter are the surgeon and the surgery they're having. Because he or she will say, I always give X number of pills for this and X number of pills for that. And we also know that they were far too high. We were not focused on how to better manage those people. And so we knew that we were going to give people opioids. We knew they were going to have this exposure, and yet we weren't really doing anything to think about a preventative approach to the opioid epidemic. And I will say, as I go later into this conversation, you'll know that that's where we started in 2016, but we've really started to handle more of these downstream effects now through surgery as well. We also know that the relative contribution of surgery, dentistry, and emergency medicine is increasing. And these data are probably old now, but still one of the only studies that's really addressed this topic. We are repeating this currently. These data predate the CDC guidelines, so they're about 7 years worth of data from a national private payer data set, where we looked at people who had not filled an opioid for a year prior, and we said, who gives them that next prescription? Or potentially that first prescription. So we would call these people opioid naive. For a full year, no opioids, who gives them the opioid? And this is what we saw is that over that 7-year period, the bottom category in the yellow, which is largely made up of primary care physicians, because even today, primary care physicians still write the majority of opioids because primary care physicians do the majority of care. But during that time, the relative contribution of surgery, dentistry, and emergency medicine increased in a meaningful way. Not only that, when we broke it down to something called OMEs, or oral morphine equivalents, we saw that patients in the surgical category in particular had a major increase in the amount of opioid that was prescribed over that time period. And when we really just focused in on the last 2 or 3 years, surgery remained high and flat, dentistry was flat, emergency medicine increased a little. In the bottom category, in the yellow, again, mainly primary care physicians, not only decreased the number of times they were writing, but also the amount written per prescription. And so the way I sort of take this back is to say that predating 2016, the lack of guidelines for surgery, dentistry, and emergency medicine were really leaving it in a position where acute care wasn't following the good work that was happening through primary care. So why do surgeons prescribe so much? Well, I have, there are 2 of our colleagues who run this initiative, are surgeons. We work with surgeons. I like surgeons. They're my friends. And frankly, as a pain physician, I could say I could replace surgeons with pain physicians or dentists, or you really could put anybody in here, because these pressures and these things are very meaningful. We know this from both informal conversation and formal qualitative studies, that things like time, concerns about refill requests, satisfaction with care, and even the links between satisfaction and payment all drove increased prescribing. But good news, we now know from multiple studies across multiple types of data, surgery and dentistry, that the number of pills prescribed is not associated with satisfaction, nor is the number of pills prescribed associated with the likelihood of refill. So let's take those apart. Refills happen. If you look at abdominal surgery, about 7% of people will refill an opioid. If you look at a total knee replacement, it might be something like 30%. But when I take that abdominal surgery condition and I look at the equivalent of less than 6 pills of hydrocodone or more than 60, the line is flat. Same for total knee replacement. If I look at less than 15 pills or greater than 150, in fact, if anything, as you go to that 150 number, the line appears to be higher, and it doesn't matter whether we adjust for factors or not. Really what it comes down to is that we're prescribing too much, or were at least at some point prescribing too much, and that we were doing so to try to avoid refills or people running out, and it wasn't changing that outcome at all. Not only that, I think this satisfaction thing, I clearly understand why surgeons and dentists care so much about satisfaction. I care about it. I want people to be happy, and it's important for business. But if you have a bad encounter with a patient and all of a sudden, because you didn't prescribe enough, they get really grumpy, and you start changing your prescribing, you are now overprescribing to the majority of people because of an encounter that may have been avoidable regardless of the amount you prescribe. So what do I mean by that? There really is no association. And again, we've looked at multiple types of data, and we've had big multi-site data, we've had smaller quality improvement data. People's satisfaction with their care is not associated with the number of pills prescribed. Instead, it's a lot more about how you treat them. Do you care for them? Do you call them when they call you? Or are you taking care of them in the way that they would want to? And so our pain clinic, a tertiary care pain clinic, where generally by the time somebody's come to see us, they've already seen another pain physician. They've usually failed care at another location. Most of them are on opioids already before they come to see us. And despite that, our satisfaction is actually the 5th highest of all clinics in our health system. We have about 150 clinics in our health system. We are the 5th highest rated clinic, all because we actually started working with Zingermans. Many of you will know Zingermans. We work with ZingTrain, and we started doing customer service training and thinking about patients like customers, not customers like paying customers, but like people in your restaurant or people in your home. You wanted to show them good customer service. And we started thinking about how we interact with people, how we appreciate them, and how we contact them. And now the only remaining problem in our clinic are the physicians. And I know any of the nurses and MAs out there listening in won't be surprised by that. I'm kind of joking, but I'm not. I mean, honestly, the remaining problems are the physicians. Our check-in, check-out staff are incredible. Our call center is just amazing. And it drives better satisfaction, not opioids. We actually wean people off opioids commonly, and we aren't quick to prescribe. Now, while I was interested in that because I knew both of those factors would drive prescribing, I was also really interested in this. How often does a person coming in not using opioids before their surgery go on to become what I would call a new persistent user? In other words, they were not using opioids. We have either prospectively collected data, or when talking about a claims data set, we have a year's worth of data to say they weren't prescribing, they weren't filling an opioid. And what we found, and this is probably the article for which we've had the most press, we took a case mix using a national data set of both major and minor surgical conditions. And what we found is that about 6% of people continue to fill long past what would be deemed normal surgical recovery. So their surgery was over, they should have healed, and 6% of people kept filling. And it didn't matter whether they were having major surgery or minor surgery. In other words, this is not just chronic post-surgical pain. Most of my NIH funding is actually for chronic post-surgical pain. And what I can tell you is new chronic opioid use after surgery is distinct from chronic post-surgical pain. There is some overlap, but it is not nearly as great as you would expect. And I wasn't surprised by that because we actually had this study from Jenna Gessling or Jenna McAfee now, showing that 4% of hips and 8% of people undergoing total knee replacement became new chronic users. And this is prospectively collected data. So we had gold standard measures. We interviewed patients. We knew they weren't taking beforehand. 8% of the knees taking it anew afterwards. And what we found, and this is actually very, very interesting, what we found was that this 8%, it didn't matter whether their knee or hip got better or worse or stayed the same. There was no association between that development of new chronic use and changes in their knee or hip pain, which you would have expected. So this was really distinct. 13% of hands, spine, this one's not from our group, this is from Rick Deo. 5% of elective pediatric surgeries, 10% of curative cancer surgery. It's not to say that I don't care about cancer, nor do I believe that opioids are bad for palliative care. I believe they have a role, but these are cancers for which the surgery actually cuts the cancer out. And then we have about 19% of probably the most challenging cohort, which is our breast cancer population, who has a lot of repeated surgery, chemo, and radiation. So certainly a challenging cohort, but a huge number of patients becoming new chronic users. And if I flip it around and I was to say something different, some have argued our definitions, they use more rigid definitions. Even if you cut our definitions in half, becoming a new chronic opioid user is the most common complication after elective surgery. The most common complication, because I consider it a complication. I'm not talking about opioid use disorder or opioid addiction. I mean a person now dependent on opioids. Some percentage of that population might be misusing their opioids. I can't tell from the data that we have, but just a chronic user has its own morbidity. Nausea, vomiting, constipation. There's challenges to just becoming a new chronic user. And so I told you this is not just chronic post-surgical pain. So what factors do we see associated? And these are the associated factors that we see consistently coming up from data set to data set. Anxiety and depression. Not surprising, but I think one thing to remember with anxiety, and for those that have ever cared for a patient in an inpatient or acute care crisis, when they're really anxious, if you give them a little bit of fentanyl intravenously, they calm down immediately. And maybe their pain gets a little bit better, but honestly, one of the things that we need to know about opioids is they do allay anxiety. Now, they don't do so in a positive way, and the long-term effects of opioids for anxiety is actually incredibly poor, but they create this short-term change in anxiety. And we hear this for people with opioid use disorder, people with addiction who say, you know, the first time I took an opioid, I felt, quote, normal. I felt like everyone else feels, or I thought everyone else feels. And then eventually you just can't keep up with that. And eventually opioid use disorder kicks in when people are unable to manage their symptoms further. Sleep problems. We have all had friends, family, patients tell us, I didn't really have a lot of pain, but I couldn't get to sleep, so I took one of my opioids. And the problem with this is that this is not normal sleep. It's not a good way to get sleep, and it's a great way to develop dependence. Remote opioid use. This one's interesting, and we have new data coming out here. It's conceptually not. It's conceptually pretty clear and simple. The idea is that when you come in for your surgical episode, you're not using opioids. So I would call you opioid naive. But if I were to interview you a bit more closely, those patients that have a history of chronic use of any kind or have shown it will be more likely to become new persistent users. And that might be because they, quote, like the meds. That's where everybody immediately goes. But I think the other important thing to remember is that also means they can tolerate them. About 7 out of every 10 people who you give an opioid to will have some sort of adverse event, nausea, vomiting, or constipation. And for some people, that's just too much and they won't do it. These people have oftentimes already shown the ability to tolerate it. And then on the right, these again probably seem obvious, but chronic pain conditions. And what I mean is that I said this is not just chronic post-surgical pain, but I'm talking about people who have chronic pain coming in. About 1 in 3 Americans lives with chronic daily pain. Many are not on opioids. They come in for their abdominal surgery. Now they're taking an opioid. Maybe their knee feels better. And the data would say that for about 8 to 10 weeks, your knee might feel better. But unfortunately, when we go out about 1 year, we see no difference and probably even worse effects from those taking opioids in the majority of patients. I think it's about 10% of people seem to respond, and we can't really figure out who those people are. But now when they're calling for refills for surgery, are we always asking people why they're taking it? And then substance use disorder and tobacco use seem obvious, but honestly, and I give, again, lectures to major surgical departments all over the country. And while this seems obvious, I'm really not aware of any groups out there doing high throughput, non-stigmatizing screening for every patient coming in for surgery. I already told you, they're all gonna get an opioid, and yet we're not screening because none of our measures are actually validated for use in acute care. And so I think this is a huge opportunity in a place where we're working. And I've talked a lot about surgery, but dentistry is a problem when it comes in dentistry. While I don't let groups push back, outside the US, I'll often hear, oh, this is an American problem. Well, dentistry and dental prescribing is our one really unique American problem. We are one of the only places in the world that will routinely prescribe opioids to people coming in for dental care. And so this is a national private payer data set, 70,000 young men and women, 13 to 30, undergoing wisdom tooth extraction, something we do about 5 million times a year in the US. What we found was that about 78% of people after their tooth extraction, after their wisdom tooth extraction, filled an opioid. Okay, this is despite the fact that there are level 1 data, meaning randomized controlled trials, showing that acetaminophen and ibuprofen is superior to opioid for treating pain. 78% of people filled an opioid. And just filling an opioid, after adjusting for demographics, pain diagnoses, psychiatric diagnoses, comorbidities, and even the impaction status of the tooth, which is in the data set, just filling that opioid was associated with a nearly 3 times increased adjusted risk of becoming a new chronic opioid user. So if you start to think about that and project that out, this is a major issue. And again, one that where I think this was one of our first studies, and this is from a few years ago now, really showing that just filling a prescription seemed to matter. And we're now seeing this with surgery as well. So some of you will know this, but others won't. Our state, and we're not completely unique here. There are other states that have a dominant private payer, but Blue Cross Blue Shield of Michigan is our state's dominant private payer. And so they had the foresight, and this part is unique. The Blue Cross Blue Shield of Michigan had the foresight more than a decade ago to say, if we could bring physicians, And if we could bring people around, if we could bring people from around the state together to talk about quality, talk about better care, then we can improve care. And so this is what's happening. This is just a couple of our collaboratives. This is MSQC, which is the Michigan Surgical Quality Collaborative, General Gynecologic and Vascular Surgery, reaching all 73 major hospitals in the state. And then Aspire, it was our anesthesia collaborative, which actually connects with a lot of these. And there's other surgical collaboratives, but I had been going to meetings before Michigan opened. I had been going to meetings for this for a couple of years, just marveling at the fact that you could bring a surgeon, a nurse, and have Blue Cross in the room and talk about quality, openly share that here at Michigan Medicine, we could have a group just down the street at St. Joseph's Hospital. We could share information and share quality to try to make things better without that feeling of competition. And so actually, for those that need to know, you actually have a better chance at having quality surgical care in our state, more so than any state in the country. And we had a former president of the American, one of the big American surgical societies come in and say, here at one of the state's meetings, say that she recognized that the quality improvement here in Michigan and about the consistency and quality across our state. Well, we overlay this over an old version of our overdose map. And what you can see is what it meant is we were able to really touch regions, and those white areas are actually just no data available. We knew that we could get data from around our state. We went to Michigan Department of Health and Human Services back in 2016 and said, hey, we want to use data from around the state. We want to use this platform of existing data collection, existing collaboration to understand real world prescribing. We want to make recommendations and we want to disseminate those. And so our concept was that if we made prescribing recommendations, that prescribers would reduce their prescribing. And what I didn't show you is that if the more you give a person, the more they consume. So we now know this from multiple studies. For every excess pill you prescribe, people will use an extra half pill, which is a huge effect, an enormous effect. Every extra pill, the person will use an extra half pill. So you give them 10 pills, they're gonna use 5 more. If you give them 50 pills, they're gonna use 25 more pills. Big, big number. And if you give them less, they use less. And I'll show you data on that in a minute. But we would reduce prescribing. And then I think a major differentiating factor of our group, and one that's been a little harder with COVID, but we'll get back to it, is updating our recommendations. That we won't just say, hey, here's the number and we'll walk away. Because honestly, if I tell you the more I give you, the more you'll take, then what it means is that as I reduce, you'll take less, and I need to update because I need to keep an eye on that. And so we've been doing that, and we've been monitoring satisfaction and patient-reported outcomes like pain throughout. And so what do we have? These are our most recent prescribing recommendations. I discourage people from taking pictures because I think as I said, we update these. So I encourage you to go to the website because we do keep these updated a couple times a year. Obviously, we haven't updated in 2021 yet, just because of the decreased data flow, but we expect to here soon. And we recognize that we haven't captured all surgeries here, but we have tried to get a broad swath, and we have hopefully gotten to a place where surgeons can look and say, my surgery is a bit like this one. You'll also see the leading zeros. We used to just have a number, but what we found was that, and this was actually first shown by a group out of Dartmouth, the most accurate predictor of how much a person's going to use after they leave the hospital is the number of pills used while in the hospital. And again, not rocket science, but it's pretty interesting. And so not surprisingly, if you use 0 pills in the 24 hours before you go home, you tend to go home and use 0 pills. And some people don't want opioids. And so we're trying to put this out there as an option. So this is the effect of Michigan Open. These are data from around the state, including your side of the state. This is from about 43 hospitals. These are data from predating our group. This is the average number of pills. This is number of pills prescribed, putting in the equivalent of 5 milligram oxycodone tablets, pretty common number. And what you see is that before we started, people were getting about 40 pills on average. We started talking and working with the MSQC in 2016, we saw a decline, and then we started to release our prescribing recommendations. And we've seen prescribing decline year over year until recently with our third iteration of our prescribing recs, where we might actually be flattening out. I don't know that there's much room to go down here except for potential for elimination in some people, but there's still some work to happen there. As you can see, though, we're starting to decline. And what's exciting is that, you know, early on in our efforts, I would get questions from friends, family, lay press. How come in Sweden? How come in Denmark? How come in Germany? Whatever, you know, they would pick a country and say, how come they can get away with so much less? And what you see now is that across our state, and these data come from tens of thousands of people, multiple hospitals. We didn't come in with a specific secret sauce, but you see that across that, we're starting to prescribe like our European counterparts who have been prescribing less for a long time. And despite the feedback that I get on Twitter from patients who think I'm the devil, you can see that if you take a snapshot from that 2017 mark, here we were prescribing about 30 pills on average. We got down, as I said, to around 10 pills. And as we declined, we also see this dashed black line showing that as we decrease our prescribing, consumption also decreased. So people took less pills, taking on average about 5 pills. And satisfaction stayed high and flat. This is satisfaction and pain over here. And pain stayed low and flat. So we haven't, you know, these data are for about 40,000 patients. And as you can see, despite huge decreases in prescribing, we have not adversely affected pain or satisfaction. Now, we're repeating these analyses. This was admittedly quick and dirty, but we just looked and said, okay, well, what about like a couple states like Indiana and Kentucky? And what you see there is in the blue line is we decreased our prescribing despite having policy limits, because we've actually now published a few papers showing that these state policy limits, day limits, actually don't really affect surgical prescribing, because in many cases, the amount that people prescribe is well under that. Even here, though, with Kentucky having a 3-day limit, which is much more rigid, you see much more variance. And, you know, right now it looks like as you go to the end of 2018, our change was less and we saw a lot less erratic prescribing. But then I think we're really excited about this. These data are nearing, they're under review currently, but we looked across that same data set that I showed you with the decrease in prescribing, and the MSQC, despite being funded by Blue Cross Blue Shield, definitely Blue Cross never says, well, only help Blue Cross patients. Quite the opposite. They just say, hey, just improve prescribing. And so our question was, well, if we did this across multiple hospitals, would it disproportionately affect Blue Cross patients? And as you can see, it did not. We saw equal drops in private insurance, Medicare, and Medicaid. And so this is where we started with our original goals. We wanted to reduce opioid use. We wanted to educate providers and communities. We do talks pre-COVID. I was probably doing 1 or 2 talks like this a week. But then this middle category, I think, is still a place where we have to bang away. This elimination of unnecessary opioid exposures. As I said, I think opioids have a role. I think there are many surgeries for which they're reasonable. I think there are times in chronic pain when it's reasonable. But we have a whole lot of cases in which opioids are not necessary, and yet they're routinely prescribed. And I think this is an area that we would like to do some work. I think there's a lot of surgeries out there that could go without an opioid, not because I'm concerned. Everybody immediately jumps in and says, oh, you know, the risk of addiction is so low, or the risk of dependence is lower than what you say it is, Brummett. This is not something worth doing. I think people forget that the morbidity is so much. And what do I mean by that? I mean that people, you know, I said 7 out of 10 people given an opioid will get sick or have nausea, vomiting, constipation, itchiness, sedation. These are medications that are poorly tolerated. And so if we really want to think about recovery and surgical recovery, and we can offer similar pain control from a short course of ibuprofen and Tylenol, then we really need to give this some thought and consider eliminating opioids where possible. And so to that end, we have done some work here. This is from a opioid sparing pathway that actually Blue Cross incentivized. They put a financial incentive there. It was supposed to really focus on surgeons giving to a select group of patients uh, education about their care. They were given strong encouragement to use acetaminophen and ibuprofen around the clock, and they were given some rescue pills. Generally, this ranged from about four or so pills, 4 to 6 pills. And what you see is that in this group, the median opioid use became 0 pills. People had about 2 left over. And pain score was very well controlled, and satisfaction was very high. And when we do, this is admittedly a messy case control study where we compared those who did not get an opioid prescription to those who did receive an opioid prescription for similar surgical types. What we found was that actually people who did not get an opioid reported less pain. So we used a 1 to 4 scale. This was because 30 days later, they're being asked to remember in that week afterwards, did you have either 1 was no pain, 2 was minimal pain, 3 was moderate pain, and 4 was severe. When we asked people using that 4-point ordinal scale, I don't know that this is actually clinically significant, but you at least see that there was no bad signs. Satisfaction was high, quality of life was reasonable, and level of regret, while people didn't actually take the opioids that they were given. And I think this matters, and we're coming off the heels. I'm hoping that you guys had some opioid drives or some medication take back drives in your side of the state last week. This has been something we've been organizing for a long time because, true to our narrative, one of the most common reasons for people to have excess pills in their house is from acute care, surgery, and dentistry. And actually, this is the first paper by Hill showing that about 70% of what people were prescribed went unused. And if we think about that and we do it in terms of math, and we want to put some math in this for our state, we do 1.8 million surgeries per year in the state of Michigan. It was about 33 pills in excess when we first started thinking about this, meaning that there was about 62 million unused pills each year just in the state of Michigan, just from surgical prescribing. And so if I was to put this out in the big house, a place that we hope will be full and exciting this year, and we were thinking about the area of a hydrocodone tablet, this is what 1 year's excess prescribing would look like. And we would need about 3/4 of our hockey arena as well to do that. And this matters because when you poll kids 13 and older who admitted to misusing or abusing an opioid in the year prior, what you see there is that more than half get them for free from a friend or family member. And about 17% of them have them left over from their own care, common from surgical care, dental care. This is where kids get them and they have them and they know they're available. In fact, I did a lecture for a group of juniors and seniors here in Ann Arbor a few years ago. And I said, how many of you, it was 100 kids, juniors and seniors, health policy classes, and how many of you could go home and within an hour access an opioid? 3/4 of the kids immediately raised their hands, immediately. And that really surprised me. But it turned out that mirrored the national data. So that's why we've been really interested in disposal. And these are data from our drive from almost a year ago now, where we had pulled together 96 communities. And I understand the DEA does drives nationally. However, we recognized together with law enforcement, so they've been our partners from the beginning, even before Michigan Open started, that there was a major issue with having opioid drives in law enforcement offices. Many people didn't feel comfortable taking their pills into a police station or a sheriff's office. And so we opted to try to make these community-based events in partnership with law enforcement or in partnership with a pharmacy. And so these, about a year ago, before COVID, we were able to organize these 97 sites, and it's a ton of fun, and certainly seeing a lot from your community, and some of on the call today may have been involved in those events, and if so, thank you. We just had our Ann Arbor event on Saturday here as a part of that statewide event, and we did our first drive-through because of COVID. I wasn't sure what to expect. We normally get about 500 pounds of pills in a 4-hour period here. We got about 850, so a much bigger turnout this year, and I was overwhelmed by positive response. So we're after this, I'm going to guess we'll be somewhere around 16,000 pounds of pills out of the community. Unfortunately, still a drop in the ocean. And so we really want to think about pushing this into an everyday activity. And so this is one of the educational opportunities available through our website. We have made this poster that you can actually get sent to you. You can actually also get it branded, so you can send us a high resolution logo of your practice. We'll stick that practice logo on the front of it, send it back to you, and you can get it printed to put up around your clinics, because we think it's important to start the conversation. And you see we have QR codes here for people to click on there to learn more about education, and also to find disposal sites near you. We have a map on our website of approved disposal sites, because not all places will take back opioids, as many of you know. But ultimately, I think this is where it has to go. And I have no stock in doTERRA. I don't know that their product is any better than any of the other products. But we did a randomized control trial a few years ago where we randomized patients to either get usual care, meaning that for just a couple of weeks, just however our nurses educated patients. Then we started randomizing day by day, people either getting an information sheet with information on where to find safe disposal sites, so how to find a pharmacy or law enforcement near you. And then the last group got a doTERRA bag, which for those that don't know, doTERRA is an activated charcoal bag. You pour in your pills, you add some warm water, and you throw it in the garbage. It's deactivated and more environmentally friendly. And there's other companies like DisposeRx, just so I'm not viewed as speaking for doTERRA. And these are pretty cheap. When bought in bulk, I think we've seen prices around $2 or $3 per bag. And as you can see here, this, just in terms of unadjusted factors, more than doubled compliance with safe disposal. When we adjusted for risk factors, it actually was nearly a threefold increase in disposal. So I do think this is where things have to ultimately go, because people need to avoid the inertia of going to a pharmacy. I mentioned our prescribing recommendations. I've also mentioned some materials we have. If you go to our website, and I'll show it at the end, you can go in and you can actually see some of our brochures for surgery, dentistry. We have some for naloxone. Again, we will, if you send us a high resolution logo, we'll stick your logo on the front and send it back for free and clear use. This is the one about surgery. It talks about understanding surgery, safely managing opioids, knowing the risks, and on the back, how to store and dispose. And actually, these brochures meet all of the state guidelines for what a patient needs to be educated. Now, it's still supposed to be you educating them, but rather than having to make things up, you're actually giving it to a patient in a way that they'll be able to digest. And so you would be educating a patient to use these. Now, ironically, our very first paper as a group was this one, where we looked at people using opioids before surgery. So I gave you the big song and dance at the beginning about why we focus on people without not taking opioids, but we really think that there's a lot of opportunity for those taking opioids, and I'm just noticing time, so I'm going to go a little quicker here. But we really want to pivot to those using opioids, and so we're going to start doing more work in this space, screening for opioid-related risk, communicating with patients and caregivers, and coordinating care. Ultimately, this transitions of care work is incredibly important and something we want to move to, because we need to do a better job of managing people using opioids before surgery. I'm just going to skip through. So as I wrap up, and I apologize I didn't get to a couple slides. I got a little carried away apparently in the middle. We're doing a lot of work across multiple domains. We're doing a lot of work with naloxone and the EDs. And we even have a musical to try to educate our patients, and we're excited about all this work. So our ED work is now out to 22 hospitals. We're doing free naloxone distribution for patients who are admitted with overdose or admitted at high risk. We've distributed over 1,000 kits to these 10 hospitals, and we've just added 10 more, including now hospitals in the UP. We're also trying to do some work to understand genetic associations between opioid exposure and the development of new persistent use, because we think this is an important factor. And then working with the Michigan Department of Health and Human Services, we have actually made a musical with our School of Music, Theater, and Dance. It's the #1 school of music, theater, and dance in the country. These kids are wildly talented. We have this musical now fully produced. Immediately pre-COVID, we had 10 high schools signed up. We had 2 casts ready, and we were ready to go. And COVID hit, and we got stopped, as with most things. So we're working on a cast album now that'll be available on Spotify. We're trying to find creative ways that we can get this content to kids. You can hear a couple of the songs on our website. The music's super powerful. And we really think this is the way to engage kids and think, and actually working with the health department and working with Michigan Department of Health and Human Services and the high school health teachers, we're actually incorporating the content in a creative way to try to reach kids without boring textbooks or old videos. So if I was to sort of wrap it up and say, what's the most important thing to take from today? Educate patients, talk to them, set expectations, and let them know that pain after surgery is normal. Encourage things like acetaminophen and nonsteroidals. You don't have to get fancy. NSAIDs, acetaminophen, and local anesthetics work. Be very careful about co-prescribing benzodiazepines and use the PDMP. They are a friend. These are my colleagues, Mark Bickett, another anesthesiologist, pain physicians. Mike Inglesby is a transplant surgeon, runs the MSQC, awesome guy, runs a lot of our Blue Cross collaborative work. And Jen Walgie is the hardest working person on our team, definitely the smartest person on our team, plastic surgeon, hand surgeon. And this is some of the team. We're a big group, and it's been a lot of work, but also a lot of fun. And so with that, I'll say thanks and take questions.
Thank you, Dr. Brummett. At this point in time, we have a question. If anyone wants to, please put your questions in the Q&A box. So the first question is there any way to get a list of the references for this lecture?
Yes, actually, we have on our website our key references. So they are there. The key publications are on our website, and you can find a lot of that as well as some summaries.
Okay, all right, very good. So, and the website is here. So, okay, perfect. A question about the DTERA packs that you were talking about in those disposal packs. What is your, as you're going through and the information, do you have a goal for how providers will do that? Will it just be something that just comes automatically with any prescription they write? How do you perceive that happening?
Yeah, it's a great question, and I think there's a lot still we don't know. So we did that one study. There have been a couple of follow studies. There was a pediatric study that followed up, and I think there's a lot of room here because the question is not just who gives them, but where do they get them? Should they get them by the recovery room nurse? Should they get them at discharge? Should they get them at the pharmacy? And I guess my biggest point is that they just need to get them. And so I think each group's gonna have to work through their own workflow. There's always the question too of who's gonna pay for them. And I think that's a great question. We've seen some legislation in some states requiring some type of disposal package with prescribing. I'm mixed on that because I would like to see something a bit more tailored. If you're a chronic opioid user and you're using opioids month over month, I think if you're getting DTERA bags every time or any kind of activated charcoal bag every time, you're just going to accumulate them. Or I don't know, maybe you could do some good community service and give it to friends or family who may have extra pills. But so I think there needs to be a little bit more thought on who we give it to, but I certainly think for surgery and dentistry, this makes a lot of sense. Our bias is that the discharge planner and then the recovery room nurse are the people doing education. You've got a really attentive person and family member usually at that point, and they're listening in a way that they don't often listen when they come to the physician. And so I think that's an opportunity, but I'm mixed about putting this into retail pharmacy. I don't know how you feel, but I always am super empathetic to retail physicians. Retail pharmacists, every time I go in there, they look so busy. So I think there's a lot of work here still to reach to workflows. I just think it's important that you think about it within your own care and how it would be best for your patients.
Wonderful, thank you. All right. Question about the brochures. Can the brochures be given to an SUD program also can SUD programs get the bags? So the deTerra bags, I think they're speaking about.
Anyone can order the bags. I mean, they're fairly straightforward to order. You can actually order directly from the manufacturer, and there's discount in bulk. We're buying about 10,000 here soon because we're doing some work with a community organization in Detroit that's doing in-home visits for other health-related needs. And so thinking about giving those out as a way for in-home disposal. So, you know, they can be ordered for sure. Brochures can certainly be used for SUD clinics if they're appropriate. You know, our work is really, I think, distinct. While we're doing a lot of work on how to best manage pain for people with opioid use disorder coming through, most of our brochures aren't really specific to SUD, but you can certainly look through, and anything you see in there that you like, you can fill out the form. It's quite straightforward. You fill it out, you give your details, and if you want them branded, you put in your logo. And generally, our process is about a week to get it back to you.
Wonderful, thank you. Another question, do you have any suggestions for persuading other providers to not prescribe so much? I find that many providers will recognize that prescribing chronic opioids is a problem, but when it comes to their own patients, they continue to give refill after refill because I don't want the patient to be in pain, unquote.
Yeah, I mean, it's interesting because the chronic pain situation should be further ahead given the CDC guidelines predate any work we've done here. And yet I know that we've already moved past primary care pretty quickly, in some ways because what we're doing is easier, I will say. That said, my strategy is generally to engage someone like them. In other words, finding a provider who is of the same specialty, same, you know, so if it's a primary care provider, another PCP, but not just another PCP with a similar looking practice, right? That could be a small private single physician practice or a group practice, whatever that is, because while there's a need for someone to give the thought and education and lay the framework, they also need to hear from someone that looks like them. And so we do this with dentists. We have a dentist we work with. We're working with orthopedic surgery. We bring an orthopedic surgeon, and not just any orthopedic surgeon. If it's foot and ankle, we bring a foot and ankle surgeon. If it's a knee surgeon, we bring a knee surgeon. And so I think people hearing from their own is incredibly important. And stories matter. Stories matter a lot. And not just stories of loss, but stories of success. You know, hey, I used to feel exactly like you did. I used to be convinced I needed to prescribe all this opioid, but I've stopped and or I've reduced and here's what's happened. Those stories are powerful and they change prescribing.
Wonderful, thank you. Another question, could you speak a little more about patients being 3 times more likely if they refill a prescription? Specifically, I'm confused about the determination/comparison if somebody does not fill the prescription. If they don't fill the prescription, how would they be at risk?
Yeah, it's a great question. So we wanted to recognize that some places, and we started with surgery, but I mean, started with dentistry because we know that actually there's enough data now and has been for a long time to say that dentists shouldn't prescribe for tooth extraction, which is about 2/3 of the dental prescribing is for tooth extraction. And so we're able to tell who did and didn't fill an opioid from the data set. Our definition doesn't include that index fill. In other words, the first fill isn't part of that definition of what we call new chronic use. That's more of the delayed fills. And so, you know, while it seems like it wouldn't happen, there are people who don't fill, but go on to fill later and become new chronic opioid users. What we wanted to see was what was the associated factor of that, just that first fill. And so I'm not even talking about a refill there. So that index fill, that fill around the time. And so we usually do a 0 to 3 day range after the time of surgeries, from the day of the surgery through 3 days. And we see that just getting that first opioid is associated with more chronic use. And maybe that seems obvious, but it's certainly not seemed obvious to many surgeons and dentists with whom we've worked.
Okay, great, thank you. All right, I think I saw another question pop up, but I don't see it right now.
What would be your best strategy for rural health opioid awareness? What would you? Yeah, I mean, our strategies. We've been working across the state this whole time, and the work we've been doing has certainly affected your community already, whether palpable or not, because we know that because we see the data from across the state and all the hospitals across the state. The rural population is it's different. I mean, I think people come from a long way to get their care, and so that's a different factor. We've been trying to do some work with our friends in Traverse City because again, like sort of a catchment area with large rural population. Um, and I think, keeping it with people who they trust matters. Engaging patients and communities is important. But, I think first you got to figure out where the problems are, if there are problems. The good part about physicians is that they tend to all map back to a hospital. It's been one of the challenges with dentists, and that they tend to be sort of many solo or small practices, but almost all physicians have admitting privileges somewhere and have credentialing at some point. And so we tend to work from the hospital outwards, and we tend to work at the provider level. It's not to say policy is not important. Policy is important. Payers are important. All these things are important, but we believe in sort of education at the provider level.
Great, thank you. Okay, I don't see any more questions at this time, and we're close to time to wrap up. So any last words, Dr. Brummett?
No, just want to thank you for what you do and appreciate it. And I love your part of the state, no doubt about it. It's some of our favorite places to go. So really appreciate the opportunity to share and the continued connection.
Okay, great. Thank you. Thank you very much. It's just was a wonderful talk and full of facts. So thank you. Thank you ever so much. So,
Wonderful. Take care. Thanks so much.
yeah. Okay. For those, I will put up the slide again for your CMEs to share, and the link was in the chat. So, so thank you all for attending, and we look forward to seeing you the rest of the week. The link you received when you registered will work for you throughout the week. So thank you ever so much for attending. We look forward to seeing you again. Bye-bye.